good morning, afternoon, and evening from wherever you are, and welcome back to another episode of the Unveil the Future podcast 2025 edition. My name is Van Nguyen, your host, and today we are absolutely thrilled to welcome back one of our esteemed 2024 VinFuture Special Prize Laureate for Innovators with Outstanding Achievement in Emerging Fields. This episode dives deep into the pioneering work of Professor Carl June from the University of Pennsylvania, USA. Building upon the foundational concept of Professor Zelig Eshhar, and also collaborating with Professor Michel Sadelain and other renowned scientists, Professor June has been instrumental in developing a new generation of engineered T cells, which led to innovative cellular immunotherapies for various cancers, including leukemia and lymphomas. His significant contributions have not only revolutionized cancer treatments, but also paving the way for more innovative therapies to cure other critical medical domains, including the HIV. Join us today as we explore the newest advancement of his research and also discussing the prospect of CAR T-cell therapy for the future of medical technology. Professor June, it is an absolute pleasure to welcome you back after your 2024 VinFuture Prize Award ceremony. And once again, congratulations for your well-deserved VinFuture Special Prize. And now looking back, how has this recognition influenced your further research into CAR T-cell therapy, and particularly as it expands beyond leukemia and lymphoma into neurodegenerative diseases?
Well, thank you very much. My visit in early December last year was really very exciting, and I think it's going to prove to be very useful for both us in the United States and in Hanoi and throughout Vietnam. And it was good because it brought out to the public their very new findings in medical therapy, and then what Vin University and VinFuture is able to bring to Vietnam. And so it hasn't just stopped with that. We're having ongoing discussions with the professors at Vin University to establish trials between Vietnam and the United States, and so that we can bring new technologies in that will benefit patients with cancer there in Vietnam.
That is indeed such an exciting news, learning that the two nations have joined into a collaborative initiative. And given that the VinFuture Prize is still originated from Vietnam, a developing country, what personal significance does this award mean personally to you? And moreover, how do you believe that the VinFuture Prize distinguishes itself amidst other prestigious honors that you have received?
Well, I think it's really great for new technologies to come in, to developing countries. And that has happened, like one well-known thing is how in Africa, cell phones, were introduced really before landlines, for telephone communication. And so that really has made things much better for the people there. And so that, bringing in new therapies and technologies into Vietnam, as you have a workforce that's growing and universities now, I think that you'll find in a developing country that there's many new opportunities in Asia for you. I think it's very similar to what's happening in India, as a very large developing country, but there they've done the same. And it's been very useful for India to bring in many new technologies. And then locally, they're doing a lot to expand and make it useful for their people.
And given the significant resource that your research require, does the 2024 VinFuture Special Prize make a meaningful contribution toward advancing your further research?
Yes, it's first of all, it's very exciting for us to be able to work now with the people we met in Hanoi at Vin University, so Professor Lim and others now, we're able to, that's very exciting to be able to conduct trials and because it turns out, cancer affects everywhere in the world. But the actual kinds of cancer and the causes and the treatments are different in different geographic areas. So it's very important that the new technologies are brought into Vietnam so that they can be used, but they need to be adapted to be specific for actually what kind of cancer that people have. So locally, I know in Vietnam that um, one of the most common cancers is lymphomas. It's a blood cancer, and we also have that. But in Vietnam, there's some data that those cancers, were caused by some of, from the war with pollution, with agents like things like Agent Orange, used to kill trees and so on. That has gotten into the system, into the groundwater, and people are exposed to that, and it actually may even be able to affect the next generations of people born in Vietnam. So it's important that you have therapies there, to treat whatever illnesses there are. And that will extend, from cancer. There are different issues with autoimmune disease in Vietnam. There are also differences in, um, the kinds of um, subtypes of cancer, for instance, in the liver that we get are different than what you have. And so you'll need to have specialized cancer therapies.
And now turning to the CAR T cell therapy, which has revolutionized cancer treatments, could you share one of the most significant advancements in the field over the past years, and particularly expanding CAR T cell therapy beyond just blood cancer?
Yeah, sure. We have it began in 2010 at our University of Pennsylvania in Philadelphia. And the first two patients we treated had very advanced blood cancer, and they're both cured. Patient number two came back to our hospital last year for a checkup. He's now 78 years old and very healthy. And the most important thing is he still has CAR T cells 15 years after we treated him in 2010. And so we now know they can live in a human being after treatment, their own cells that are genetically modified to fight cancer, and they can stay around and continue to fight cancer cells for 15 years. So that's so different than all the other therapies like medicines you would take every day, like for blood pressure. You just have to keep taking them instead of taking something once and then it's done. So it's really important now that there are seven kinds of blood cancers that are treated in the United States. And, we're going to bring those into Vietnam so that it can benefit the patients. In the US, about one out of every three cancers is a blood cancer. So it will be a big improvement in Vietnam to have that. Now, the main thing in the last year has been advances, outside of the field of blood cancer in areas like brain cancer. So for brain cancer, there's been very few advances in the last 40 years. And now there are exciting developments in early stage trials in the United States that, CAR T cells will have use in brain cancer. So, and then I think, there will be, we mentioned liver cancer. There is, very common disease, cancer in the GI tract, like esophagus and pancreas. And all of those have very promising results now in either early stage trials or in experiments in mice, that will turn into trials in humans. So I think, in the next 10 years, we're going to see massive advancements in, it won't just be blood cancers.
Yes, and since you mentioned brain cancer, how have recent innovation, including the CAR T cells and intracranial delivery methods, have enhanced the efficacy of treatments for solid tumors and also for brain tumors? And what are the key challenges in this approach, and how are they addressed to improve the patient outcome?
Yeah, so it turns out uh, that each cancer has a, what scientists would say a different kind of synthetic lethality. So that's how you find something that means it's like checkmate in a game of chess, it's game over. How do you find that? And each cancer has a different form of that. It's also, there's an English term, Achilles heel. Where is one place that you can hit something and then it can't escape? So we found in uh, brain cancer that there were two problems in our early trials. We were treating the brain cancer just like we did blood cancer. And in blood cancer, we would infuse the CAR T cells right into the blood, like a blood transfusion. And then they would go, and the blood cancers are mostly in the blood and in places like bone marrow. And the CAR T cells got there quite efficiently. For brain cancer, we found out that it was not as efficient to get the CAR T cells by a blood transfusion and going into the blood. Only about 1 out of every 1,000 CAR T cells that we infused into the blood ever got into the brain. So they never had a chance of winning. And now what's happening is our neurosurgeons, insert a catheter that goes into the spinal fluid of the patient. And then it's a very simple infusion that takes about 5 minutes. And then, all of the CAR T cells get into the brain. And then we found much more dramatic effects that way. But then we also found, as you mentioned, dual CAR T cells. So there's an issue with in brain cancer in particular, where we would treat against one target, and then that target, the brain cancer would continue to live, but it would not express the target anymore. So that's called tumor escape. And that tumor escape then is the tumor was still happy, but it didn't have the target that the CAR T cells targeted. But it turns out if you target two targets at once on the tumor cell, it's very hard in one cell division for the CAR then to lose the tumors to lose two targets at once. So then that's a checkmate on the tumor cell. It can't escape. So you need to get the CAR T cells there, and then you need to make sure they can't escape.
Thank you for your very comprehensive explanation. And another challenge that arises, which is fratricide, where CAR T cells might inadvertently attack healthy immune cells when injected into the body rather than targeting the cancer cells. So your team has developed the base-edited CD45 CAR T cell therapy to overcome this state. And could you elaborate on the engineering process and its implication for the efficacy of CAR T cell therapies?
Yeah, first of all, there's two English words, fratricide and suicide. So fratricide comes from Greek, and it means like a brother killing another brother. And so siblings kill, or families killing each other. And suicide means killing yourself. Okay, so CAR T cells can do both. They can kill themselves, if the target they're targeting, say the target is a molecule on the CAR T cell called CD45, and that's also on the tumor cell. But if the CAR T cell also has CD45, the CAR molecule can do gymnastics and can bind to the CD45 on that very cell itself and kill itself. So that would be a form of suicide. Now, it's also true that if we, infuse thousands of CAR T cells and they go in, one CAR T cell might run into another CAR T cell that also has that target, CD45, and then it would kill that cell. And then, so that's a CAR killing another CAR cell, and that would be a kind of fratricide. And both of those are bad because you want the CAR T cells to live and only kill the tumor cell. So we used a form of genetic editing. It's a generation after CRISPR. So CRISPR engineering came out in 2012, and that's a way to remove a target from a cell. And that works in some cases, but base editing is more precise and has allowed us to make in a very large molecule just to remove a few amino acids. And then the CAR can no longer bind to it, but yet the molecule there is still happy and can do its function for the cell. Now, if we use CRISPR, that's more like a sledgehammer, and it takes out the whole protein, and then the cell is not happy. I mean, it would also be true, it would prevent fratricide because the protein is no longer there, and it would prevent suicide, but sometimes you need the protein there to keep the cell alive. And so in this case, base editing, where you just remove a small part of the molecule and keep the cell happy, is much better than the CRISPR sledgehammer approach, where it takes out everything. And so that's what we have done, and it works really well in mouse experiments now. And we can prevent CAR T cell fratricide and suicide by using base editing. It's a very elegant approach, and it's very efficient. So we're hoping to have that as a trial by the end of this year at the University of Pennsylvania. It may start early in 2026.
And also through your research, you have mentioned that this method is used to create an HIV resistant immune system. So could you please explain the base editing process and how it contributes to resistance against HIV?
Sure. So HIV, is a virus, and when the virus replicates, it comes out of the cell, and then it wants to go into another cell in your immune system, the CD4 cells. And then if that continues, each time a HIV virus goes into a CD4 cell, two bad things happen. First of all, the CD4 cell makes about 1,000 new viruses, and then the CD4 cell releases those, and then they can infect other cells in your body. But the other thing is, after the CD4 cell makes all these daughter viruses that leave, the CD4 cell then dies. And then if you end up killing all of your CD4 cells, with this HIV virus, I mean, you have AIDS. It means it's destroyed your immune system, because you really need the CD4 cells to have an immune system that works. So one way, would be nice if we would have drugs that you could give to patients that would eliminate all the virus. I mean, that can happen with other viral infections, but it doesn't. We've never had, even with combinations of many drugs, there's always been some of the HIV is left behind, and we call that the reservoir. And then, so as soon as someone stops taking the drugs, the drug comes out of hiding, the virus comes out of hiding, out of its reservoir, and then reinfects again the rest of the CD4 cells and starts the whole process again, unless you start drugs again. So we have found out that this base editing can take healthy CD4 cells that aren't HIV infected and can modify the way the virus gets into a CD4 cell. With the AIDS virus, it gets in by binding to a molecule, two molecules. One's called CCR5 and the other's called CD4. So when it binds to both of those molecules, then the virus gets into the cell, and then it's there for the rest of the life of that CD4 cell. So we have found a way with base editing to modify the CCR5 molecule so that the virus can no longer get in. And we already know from humans that some patients have they inherit a form of CCR5. It's called Delta 32. My brother actually has this, and people who have Delta 32 CCR5, you can't infect them with HIV. And yet my brother's immune system works fine. So what we're doing with base editing is to make it like those patients were born with the Delta 32, and their immune cells then that they have will be resistant to HIV infection. So the base editing technology will allow us to do that. We would have to take some stem cells out from the patient and then use this base editing so that they have the equivalent of the Delta 32 form of CCR5, and then their body will become populated because the stem cells will end up making T cells and CD4 cells that have the Delta 32 form and that's resistant to HIV. And then the patient should eventually be able to stop taking medicine because they'll have natural resistance to the HIV virus.
And given everything that you have shared, it is clear that CAR T-cell therapy is a major breakthrough offering hopes for patients with cancer, HIV, and also other serious diseases. So, however, the high cost of CAR T-cell therapies remain a serious challenge. What strategies are being considered to ensure that the CAR T-cell therapy for HIV are accessible to patients in lower resource settings? And what steps are being taken to making them more accessible globally?
That's a really good point. So first of all, when I was there last December, I pointed out that the first patient ever to get cured of lupus was Vietnamese. And she was in Germany, and she was an 18-year-old student, and she had very bad lupus, an autoimmune disease. And lupus is very expensive to treat, and it also kills about 30% of the patients within 10 years. And she was treated with CAR T cells in 2019, and she's now, it looks like cured. She's had no further treatment. She's now practicing in Germany and healthy. Now, so that was done, at the cost of what's done in Germany, which is like in US. It's expensive, but the fact that it was only done one time means for that particular patient, it's already cheaper than what would have happened because otherwise she would have been, there's no curative therapy for lupus. She would be on continuous therapy that's very expensive and also more toxic. So one way CAR T cells lower costs is that it can be like one and done. You don't have to keep taking medicines lifelong. They're expensive. Like HIV, everyone has to take medicine the rest of their life. So one way to lower cost is to have, a one-time therapy like a vaccine or CAR T cells. Now, the other way is to democratize the therapy and bring it in at a way that's more matched to the economy of that population. And I mentioned when I was there, that's been done in two ways, in two countries. One is in Spain, and the other is in India now. And there, and in Spain, in 2013, one of a team came to my group in Philadelphia, and we taught them how to make CAR T cells. And then they now have done that throughout Spain, and it's much cheaper. It cost about 1/3 of what it cost us in the United States. Centers and don't have to have big pharmaceutical companies, so it's cheaper. Now, and then the other way was, it's been done in India, and the people in Spain that I taught originally now taught people in India how to do this. And their CAR T cells cost about maybe 20% of what it costs in the United States. So it looks like it's very much possible to lower the cost the cost of labor is less in Vietnam than it is in the United States. And so if you make your CAR T cells locally and don't have to import them, it's going to be cheaper. And then the other thing is that you can use new technologies to make it cheaper. And that's just like what's happened to technologies. Like, computers used to be very large and now they're small cell phones. So engineers will make the CAR T cells much cheaper in Vietnam and in other low middle income countries like India.
You have mentioned that local manufacturing and infrastructure are the key to lower the production costs. However, when it comes to medical treatments, I assume that safety is also one of the top priorities. So are there currently any clinical trials or pilot programs in lower settings, in lower resource settings, to ensure and assess the feasibility or the cost effectiveness of CAR T cell therapies in these regions to ensure that the science will benefit everybody?
Yes, and that's a really important thing to make sure that safety is not compromised. And they have now what they call real world trials with real world evidence, RWE. And they now have published some of those from Spain. And the data they have there is that the safety and efficacy, so it works just as well, but it's just as safe as what we have in the United States. So it looks like it's possible to get it more efficient and more cost effective without compromising, efficacy and safety.
And circling back to the CD45, what are the initial findings regarding the safety and efficacy of this cell therapy in HIV patients? And how do you envision integrating these CAR T cell therapies into existing HIV treatment regimens?
Yeah, so that's a great question. So for ethical reasons, we're starting that first in patients with cancer, who will basically die unless they get some experimental therapy. And for that, I mean, we've just completed the studies required to go to get our the FDA and the paperwork done that we need to open a trial. So we think in cancer patients, the base editing with stem cell insertion into the patients and the fratricide resistant T cells is going to happen by the end of this year or early next year. Then, if that's safe, then we're allowed to start an HIV. So for ethical reasons, because HIV right now in our country, as long as you have the money to buy the pills, it's really not, most people die of some other disease. And so we have to first show this is safe in cancer patients, and then we'll be able to try it in HIV. And I'm very excited about that, but that's a few years away, just because we want to be as safe as possible.
Indeed. And from your perspective, how do you envision the VinFuture Prize as an international award organization to contribute and influence medical research and innovation, particularly within regions possessing an emerging economy such as Vietnam or in the global South?
Yeah, well, I think we have a very concrete example happening there from when I was in Hanoi. So, VinFuture recruited Professor Michel Hermiston, and she has moved from the University of San Francisco to Hanoi. And she has been working for over 10 years to try to make and duplicate what we do in the United States for cancer centers. And then we're working with her and then the group at Vin University and the hospital so that they can install those, state-of-the-art CAR T cells there for trials in Vietnam. And I know she's already talking, in Ho Chi Minh City, she's talking in Hanoi, and they have a network around. And so that's a way that the VinFuture Prize, can really make a real difference in accelerating this so that it doesn't take so long to get the spread of technology, from United States and other places like Europe more rapidly into Vietnam. So I'm really excited what the VinFuture Prize has accomplished already in just a few years.
And thank you immensely for such an inspiring perspective. And as we're coming down to the final segment of this interview, what advice would you offer to the future biomedical students and also biomedical scientists?
Yeah, well, I think it's the best time. When I grew up, it was just at the beginning of computers. I mean, there was no programming languages, and then, the very early, uh, then computers happened, and then you could say, well, when the first Macintosh computer, which was a big box, was done, maybe it was over. Maybe it would not be so exciting to go into, IT, computers, and software and engineering. But it turns out, now it's like 40 years later, and it's still very exciting. I mean, now it's new generations of iPhones, new generations of AI, and so on. And so we're just as in the area of this science now, your generation is in the same place where I was when we had a big box like a Macintosh computer, and it had a black and white screen, and it's just at the beginning. And so for the next 40 years, there's going to be huge advancements in this science, and it's going to benefit people with cancer, with autoimmune disease, and with infections like HIV. So it's a very exciting time to go into this field, and I think people need to get excited about the possibilities. And the thing is now there will be careers that change in ways we can't imagine. There will be careers in academic universities. There will be careers in biotech and in pharmaceutical industries and in the regulatory science, like in our case, the US FDA. All of those things, you need knowledge of this kind of science. And so it's very important for the public to realize that, and for the students, to follow their dreams. And it's going to be an exciting career for that generation.
Thank you, Professor June, for sharing such an inspiring story and also shedding light on such a new future of biomedical treatments. And to our dear listener, we hope that you enjoy the inspiring discussion that we just had, and we encourage you to stay tuned for more exciting content. And don't forget that the VinFuture Foundation is now accepting nomination for the 2026 VinFuture Prize. Check out the link below for more information and join us on the conquest to identify and honor groundbreaking innovation with global impact. If the knowledge and content in this episode ever excites you or resonate with you, do not hesitate to share it to your network and hitting the like and subscribe button below to show support for the Unveil the Future podcast. And thank you, and I will see you in the next episode.